Welcome back to the Deep Dive. Today we are strapping in for a discussion that really hits right at the heart of complexity in reproductive medicine.
It really does.
We're talking about navigating the IVF stimulation phase when a patient has polycystic ovary syndrome, or PCOS. For the team in the clinic, stimulating PCOS ovaries is often described not just as difficult, but as, well, a true high-wire act.
A tightrope walk. That's the perfect way to frame it.
Exactly. You have to push the dose just enough to get a meaningful result, but then you have to pull back with almost like surgical precision to avoid a really disastrous complication.
It's an incredibly fine and frankly frustrating line for everyone involved.
So our mission today is to dive into why. Why do these specific ovaries react so, I guess, violently and unpredictably to the medications?
And how do clinicians manage that razor-thin margin between safety and, effectiveness? Because with PCOS, the entire philosophy of IVF just shifts.
It shifts completely.
The goal is never just the sheer quantity of eggs. The ultimate goal is quality, and above all else, the patient's absolute safety.
Okay, so let's unpack this. We hear a lot about high response with PCOS, but what exactly makes the physiology so chaotic in a stimulation setting? Why can't a doctor just, use a standard recipe?
Well, to start, we have to recognize that PCOS is so much more than just having a lot of follicles.
Right.
While a very high antral follicle count, we're talking 20 to 50 or even more per ovary, is central, these patients also typically have really elevated anti-Mullerian hormone, or AMH.
AMH is that barometer for ovarian reserve.
Exactly.
Right?
And in PCOS, the levels are just sky high because you have dozens of these small follicles all producing AMH at the same time.
So what does that high AMH actually translate to when you start introducing external hormones, the stimulation drugs?
It translates directly to hypersensitivity.
Okay.
Think of it like a sound system that's just permanently set to maximum volume. Those PCOS follicles are already primed, they're packed, they're just waiting for a signal. So when you inject even a small amount of FSH, they tend to respond too quickly, way too strongly, and, this is the critical part, they recruit way too many follicles all at once.
So it's like turning on a faucet and getting a fire hose instead.
That's a perfect analogy. That chaotic mass recruitment is the root cause of the whole risk profile.
And that hypersensitivity immediately forces a total reevaluation of what the goal of the cycle even is.
Absolutely.
Because here's where it gets really interesting. For a standard patient, you might think the more eggs, the better. You might aim for 15, maybe 20.
Right.
But for PCOS, those numbers get flipped on their head. If you get 40 eggs, that's not a celebration. That's a potential danger sign.
A huge danger sign. The goal fundamentally changes. The priority shifts to, 1, getting a safe, moderate number of mature eggs, maybe 8 to 15.
Okay.
2, making sure we use protocols that avoid ovarian hyperstimulation syndrome, or OHSS. And 3, preserving the quality of the eggs we do get.
So if you get that overwhelming number, they're all competing for resources.
Exactly. Competing for limited blood supply within the ovary, which can actually compromise the quality of eggs you retrieve, no matter the OHSS risk.
That makes perfect sense.
Yeah.
So the success metric isn't the number on the lab sheet. It's the number of healthy, high-quality blastocysts created by a healthy patient. Let's talk about that dose dilemma. I think it illustrates this razor-thin margin of error better than anything.
For sure.
So if we look at a typical patient, normal ovarian reserve, a standard dose, let's say between 150 and 225 IUs of FSH, it usually gives a predictable outcome.
Right, you get that nice uniform 8 to 12 follicles, steady pace, low risk. It's the standard.
But that predictability just vanishes the second you introduce PCOS.
It's gone. What happens in a PCOS patient with that exact same dose? This is the chaos. In one cycle, that dose might hit the sweet spot, 10 to 12 follicles, efficient, safe, great.
Right.
But without changing a single thing, in the next patient, or even the same patient in a different cycle, that same dose can cause 30, 40, or more follicles to just take off. It's a wildly accelerated growth curve.
So a single dose that's moderate for one person is basically a coin flip for a PCOS patient. It might be perfect, or it could catapult them straight into that danger zone.
Precisely. And that is the tightrope. If the clinician is too cautious, starts with a really low dose, they might only get 2 or 3 mature eggs.
And the cycle feels wasted.
The cycle feels wasted, the patient is demoralized, the cost is immense. But if they lean just slightly too aggressive, that OHSS risk just skyrockets. The margin for error is almost non-existent.
And this leads us to debunk a really common assumption.
Yes.
Just because a patient struggles with natural ovulation, they don't get a period regularly.
Yeah.
That does not mean they need a high dose during IVF stimulation. That thinking is completely backwards for PCOS.
That is probably the most critical learning point of this whole thing. Lack of natural ovulation doesn't mean a poor response in a controlled stimulation.
The opposite.
It often means the complete opposite. Because those hundreds of small follicles are just sitting there, dormant but ready. They are highly, highly sensitive.
So trying to override that with a high dose
Is exactly how severe OHSS gets triggered. The clinician has to start slow, trusting that the sensitivity is already baked right in.
Starting slow, individualizing the protocol. It's all because, as we've established, the underlying threat is ovarian hyperstimulation syndrome, OHSS.
It is the overwhelming threat. It dictates every single clinical decision we've just talked about. The risk factors are just intrinsic to the condition.
A high AMH, the high follicle count.
Exactly. They are, in clinical terms, loaded for it.
I think a lot of our listeners have probably heard the term OHSS, but maybe don't grasp the sheer physicality and danger of the severe form. Can you walk us through what's physically happening inside the body?
Of course. It all comes down to chemistry and fluid shifts. When dozens of follicles mature all at once, the estradiol or E2 levels in the blood become astronomically high. Then after the egg retrieval, all those former follicles, they transform into what we call corpora lutea. And these corpora lutea, they flood the system with hormones, including a key chemical messenger called VEGF.
VEG.
What does that do?
VEGF acts like a signal that tells blood vessels to become excessively leaky.
Okay.
So suddenly, the liquid part of the blood starts rapidly leaking out of the vessels and into the surrounding tissues, especially the abdominal cavity.
Wow.
And in severe cases, even the lungs. That rapid, massive fluid shift is what causes the intense bloating, the pain, the electrolyte imbalance, and that's what makes severe OHSS a medical emergency that requires hospitalization.
That sounds absolutely terrifying, and it explains perfectly why clinicians prioritize safety above everything else. So what defensive strategies do medical teams use to protect the patient from that specific mechanism? The strategies are robust, and they're pretty much mandatory for high-risk patients. First, they're almost always going to use what's called an antagonist protocol.
Okay, wait. Why the antagonist? What gives it more control than the older protocols?
That's a great question. The antagonist protocol lets the team block the body's natural signal for ovulation, the LH surge, instantly.
Just like a switch.
Like flipping a switch. It gives the clinic precise control over the timing of the trigger. It's a critical safety brake that the older protocols just didn't have.
Okay, so that's one. What else?
Second, they use those very low starting doses we talked about, often 75 to 150 IU, with really frequent monitoring. Blood tests, scans, almost every 2 days, ready to step the dose down if the response is too fast.
And then the trigger shot itself becomes the ultimate safety net.
Exactly. They use what we call a GnRH agonist trigger, often called the SAFE trigger, instead of the traditional HCG trigger.
And why is that safer?
Because the HCG trigger, it works, but it lingers in the body for days and dramatically increases the OHSS risk. The GnRH agonist trigger, though, it clears the system very rapidly. Using it makes the severe OHSS risk drop from high to near zero.
And finally, we see the freeze-all strategy, where the team might retrieve the eggs but cancel the fresh embryo transfer.
That's the final protective sacrifice. If the follicle count is too high or the E2 levels are excessive, putting an embryo back in and creating a pregnancy can just pour gasoline on the fire.
It makes the fluid shifts even worse.
Dramatically worse. So by freezing all the embryos and letting the patient's system completely recover, you bypass that immediate risk. Safety always, always wins.
That makes the shift from quantity to quality much clearer now. We know PCOS can yield huge numbers of oocytes, but you're saying that quantity doesn't necessarily mean high quality.
That's right.
So why is that? Is it the stress of the environment and the ovary, or something deeper?
It's largely something deeper. The sources show us that the real issues are metabolic. PCOS is intrinsically linked to things like insulin resistance, chronic low-grade inflammation, and often hyperandrogenism, those elevated male hormones.
And that creates a suboptimal environment for the egg itself.
Exactly. When those metabolic issues are present, we actually see problems with the internal structure of the eggs. For example, some oocytes have trouble with something called meiotic spindle formation.
Okay, what's that?
It's basically the essential internal scaffolding that makes sure the egg divides its chromosomes correctly. If that scaffolding isn't perfect, you get more immature eggs, lower fertilization rates. the numbers just don't tell the whole story.
So PCOS is truly a whole-body metabolic condition that just happens to express itself most dramatically in the ovaries.
That's the perfect way to put it.
And that raises a really important question.
Right.
How do these non-reproductive factors influence the cycle itself?
They influence everything. Impaired glucose regulation and inflammation, they fundamentally alter how the ovaries respond to the stimulation drugs.
So a patient with well-managed metabolism will have a better cycle.
Almost certainly a more predictable and safer stimulation cycle than one who is struggling with significant insulin resistance. And this is why pre-IVF optimization is so vital for this group.
You mean things like diet, metformin?
Diet changes, using insulin sensitizers like metformin to stabilize glucose, correcting vitamin D deficiencies, managing weight. If you ignore the metabolic side, no matter how carefully you dose the drugs, the cycle will stay highly unpredictable.
It sounds like the key to controlling the stimulation isn't just the drug dose, but really establishing a calm metabolic environment beforehand.
It truly is. The goal is to move the patient out of that state of high alert before you even start the injections.
And this all ties back to what has to be the trickiest part: trigger timing.
Oh, absolutely.
Because with PCOS follicles growing so rapidly and unevenly, the doctor has to make this agonizing choice.
It's a true compromise. You need to let the eggs grow long enough to be mature. But if you wait even one extra day, the estradiol could skyrocket.
And the risk goes way up.
Yeah. So the decision becomes balancing maximum potential yield against patient safety. And because of the dangers of OHSS, the doctor almost always has to choose safety. Sometimes that means triggering a little earlier than ideal and just accepting that some eggs might be immature.
It just sounds like an incredibly demanding process, not just for you, the patient, but for the entire clinical team.
It requires exceptional vigilance.
And we have to acknowledge that these customized, highly monitored protocols are demanding. For the clinic, it's more visits, more blood tests, more decisions every 48 hours. But for you, the patient, it can mean so much anxiety. You're wondering, why is my dose so low when I don't even ovulate? Or feeling so frustrated if a fresh transfer gets canceled.
And that anxiety is completely understandable, but that clinical vigilance is there for a reason. If we were to summarize the ideal PCOS strategy, it's a tiered approach.
Okay.
Step 1, pre-IVF metabolic prep. Step 2, low dose, step-down gonadotropins. Step 3, antagonist protocol with that GnRH agonist trigger. And step 4, high individualization. Every cycle is a learning experience.
That's a perfect summary. And our final thought for you, the listener, is just so essential here. If your clinic recommends lower doses, extra monitoring, or a freeze-all, this is almost always a strategy designed to protect you.
Absolutely.
It is not meant to complicate your life, and you are absolutely not a difficult patient. You just require a more sophisticated, finely tuned, and safer protocol to maximize your chances of a healthy outcome.
Remember, the inherent complexity exists because the ovaries are so sensitive, the response is so unpredictable, and that safe zone is just so incredibly narrow. Trust the process that prioritizes your health. The ultimate goal is always a healthy patient, high-quality embryos, and a safe pregnancy.
We really hope this deep dive helped clarify the highly nuanced nature of IVF protocols for patients with PCOS. And we do want to be very clear that this discussion was purely educational.
That's right. It does not constitute medical advice. You should always consult with your specialist regarding any medical decisions related to your care.
And if you are seeking more comprehensive information about the entire IVF process, you can find further resources at ivfforme.com.
That's ivfforme.com.
Thank you for joining the deep dive.